talking on treatment of chronic hepatitis B virus. So for treatment of chronic hepatitis virus, basically you have to remember 4 things. Whether patient has cirrhosis or not, what is the HBe antigen status of the patient, whether it is positive or negative, and what is the DNA load, HBV DNA. And fourth, what is the ALT level. So let me write it. So first, whether patient has cirrhosis or not. Second, HBe antigen positive or negative. Third, HBV DNA load. And fourth, ALT level. Okay. So if it is cirrhosis, then what is the status of the patient? Whether it is compensated or decompensated, you also have to look for that. And for HBe antigen patient, we take the DNA quantitative threshold as 20,000 IU per ml, and for negative we take the threshold 2,000 IU per ml. So why do we take the lower threshold for HBe antigen negative patients and higher threshold for HBe antigen patient? The reason is that you know that there can be a spontaneous seroconversion of HBe antigen to anti-HBe by your own immune system. Even if you don't treat with antivirals, there can be a spontaneous conversions. So let's suppose the patient, one patient has HBe antigen negative. Okay, HBe antigen is negative. It means that the patient has passed this phase and came to this phase. And even in this phase, patient has high level of DNA greater than 2000. It means that patient is not able to clear the virus spontaneously. So in that case we have to treat it. So we have kept the low threshold because the patient has passed this stage. But let's suppose one patient has HBe antigen positive. It means the patient has not gone in this phase. So patient can spontaneously clear as well even if you don't treat. So we have kept the higher threshold to 20,000. Okay. So after understanding these basic terms, now let's move towards a clinical scenario. So let's suppose one patient, he is a 35-year-old male and he does not have cirrhosis. You checked for liver elastography and there is no cirrhosis here. Okay. Then you checked for HBe antigen and let's say it came positive. Then you checked for HBV DNA and it is greater than 20,000 IU per ml. You checked for ALT level. Let's suppose it is less than 2 times upper limit of normal. So will you treat him or not? So what I told you already, he is a younger patient with no cirrhosis. There can be a spontaneous seroconversion even if you don't treat. So better observe him for 3 to 6 months for spontaneous seroconversions rather than treating. But let's suppose this patient was about 50-year-old, then in this condition you have to treat it. So age greater than 40 years or a family history of hepatocellular carcinoma, then we will treat. Otherwise, don't treat it, observe it. Okay. So in the same scenario, let me make a few changes. Here I am changing ALT from less than 2 times upper limit of normal to greater than 2 times of upper limit normal. So will you treat him or not? So in this condition also there can be a spontaneous seroconversions. So you don't need to treat unless patient is decompensated or is in severe hepatitis flare. Severe hepatitis flare, you don't need to treat. Okay. You can observe for 3 to 6 months for a spontaneous seroconversion. Okay. If there is no spontaneous seroconversion, then you can consider treatment. Okay. So let me give you another scenario by changing this from positive to negative. Okay, now let's suppose one patient has negative HB antigen negative. So what I told you that we keep the threshold 2000 for HBV DNA for in negative cases. So it is greater than 2000, let's suppose, and it is greater than 2 times upper limit of normal. So will you treat him or not? So what I already told you, that this patient has passed the stage of HB antigen to anti-HBe. So the patient is here, okay. So his immune system is not able to clear this virus, and there is high viral load. ALT is high. That's why you have to treat it. You have to treat with direct acting antivirals like entecavir or tenofovir. You have to treat it indefinitely. Okay. And if you use pegylated interferon alpha, then you have to treat it for 12 months. And in the previous scenario where I told you that patient needs treatment if the patient is in severe hepatitis flare or decompensated with HBV DNA greater than 20,000 and ALT is high, in that cases you have to treat not indefinitely but for 12 months after HBe antigen seroconversion. If you treat with entecavir, tenofovir, but here what I told you, you have to treat it indefinitely, because here the patient is not able to eliminate the virus, so you have to give a long-term therapy. Okay. And let me twist this again. So let's suppose this is negative, HBV DNA is less than 2000, and let's suppose ALT is also less. So here will you treat or not? No treatment. No treatment. Why? Because viral load is less, ALT is low. Okay, so no treatment. But let's suppose this patient, if you observe the patient and the patient starts rising this HBV DNA, rising ALT level, then you can start treatment. Otherwise, don't treat it. So this is till now we discussed about in non-cirrhotic patient. Now let's talk about in cirrhotic patients. So in cirrhotic patient, you check for HBV DNA level, whether it is detectable or non-detectable. Detectable or undetectable. Okay. And if let's suppose it is detectable, then you have to look whether the cirrhosis is compensated or decompensated. Compensated, decompensated. So here you can see the viral load is detectable and it is decompensated cirrhosis. If you follow this arm, then you have to treat it with entecavir, tenofovir. And let's suppose the patient is compensated, then you look for HBV DNA level. If it is greater than 2000, treat it. Okay. Less than 2000 and ALT normal, no treatment required. If less than 2000 but ALT is elevated, okay, then treatment is required. But for decompensated, you treat it. Okay, if detectable viral load. So now let's come to this arm. Let's suppose it is undetectable, but there is cirrhosis is there. So viral load is undetectable. That's why you have to rule out other causes of cirrhosis. Let's suppose you ruled out other causes of cirrhosis and you concluded that it is only due to HBV DNA. Then we look for whether it is compensated or decompensated cirrhosis. Compensated or decompensated. If it is decompensated, then go for liver transplantation. If it is compensated, then you can observe. Okay. So let's summarize what so far we have talked. So for treatment of chronic hepatitis B, what I told you, I have to look for parameters, whether cirrhosis or not, and if cirrhosis, if there is compensated cirrhosis or decompensated cirrhosis. Second, HBe antigen, positive or negative. Third, HBV DNA, viral load. And for HBe antigen positive, you keep the threshold 20,000 IU per ml. For HBe antigen negative, you keep the threshold 2,000 IU per ml. And fourth parameter is ALT level. So based on these parameters, whether you decide for treatment or not. And if you decide treatment, then whether to continue indefinitely these direct acting antivirals, or whether to continue only for 12 months after HBe antigen seroconversion, that depends upon the HBe antigen status. If it is HBe antigen is negative, okay, in that condition you have to go for long-term treatment. And if HBe antigen is positive, in that condition you can go for only 12 months after HBe antigen seroconversions. But for pegylated interferon alpha, what is the special feature? Whether it is negative, HBe antigen positive, negative, you go only for 1 year of treatment with pegylated interferon alpha. Okay, so thank you very much.